Good afternoon, everyone, and welcome to the Primary Care Roadmap to Recovery training. I am your host, Angelica, and I will be assisting throughout the afternoon with the training. So first, I want to thank you all for attending the webinar. Our presenters have developed some great training content, and we hope that you enjoy it today. Before we get started with our first speaker, there are a couple of things I want to go over with you. First and foremost, that this training will be recorded. And on your screen, you should see a GoToWebinar control panel. I want to point out to you some of the control panel features that are available to you for today's training. So the slide deck that we are sharing, it can be found under the handout section where you can download the document. And then another feature on the control panel is the questions and chat box. So we have reserved time at the end of the training for the Q&A session. And as you have any questions that may come up throughout the training and the training content that's being delivered, please type them in that question and chat box. There will also be a post survey included at the end of the webinar. It will pop up when you X out of the webinar. It will also be included in the follow-up email. So if you please can take some time to fill that out. It's only about 6 questions, and the survey will help us to understand if the content that's being delivered today is helpful. And we also want to know what you would like to see in future trainings as it relates to the Maryland Primary Care Program and also COVID-19. Another thing that I want to bring to your attention is that the training activity has been approved by MedChi for 3.5 credits that you can apply for if interested. And after the training, you will receive that follow-up email with the instructions and also a link to apply for the credits. And for non-physicians, you can apply for the credits as well. You'll receive an attendance certificate, and you would just want to make sure you check with your accrediting or credentialing organization to make sure that they do accept the CMEs. And most of those organizations, they do accept them to one extent or the other. So here on this slide, this is our agenda for today's training. The first topic we'll cover is an overview on the Maryland Safe Reopening Plan. The second topic we'll be covering is the Safe Reopen Plan for Primary Care. And that topic will be followed by our 3 guest speakers we have sharing their insights and also their experiences on reopening their practice. After the guest speakers speak, we will be conducting the Q&A, and then that will bring us at the end of the training with our closing remarks. We've also scheduled 2 breaks throughout the training. So those are about 10 minutes each so that it's not information overload. So the other great feature about the GoToWebinar platform that we'll be using for this training is the polling feature. So on this slide, we have added a test poll that we would like everyone to become familiar with the feature when the polls are presented during the training. So when the poll appears, you'll see a slide very similar to this that we see on the screen. Then we'll activate the poll, which will change the screen. So for our first poll that we have, we would like to see in the audience what your current role is. So I'm going to activate the poll. And on this screen, what you'll be able to do is click on the radio button, your option for the answer to the question, and we'll give it about 30 seconds for anyone that wants to participate to select their answer. Thank you for everyone that has selected. I'm going to close the poll now. So as we can see, we have about 38% of our attendees as a practitioner. We have 10% as care managers or care coordinators, 34% as administrators or program managers, 6% office staff, and also 12% other. Thank you for your participation. We do have about 4 more polls throughout the training. So hopefully that gave you some insights on how to be able to use that polling throughout the training. Right, so before we kick off to the actual official training, I would like to introduce our speakers. So again, my name is Angelica Ortman, and I have over 13 years of experience in healthcare industry. I am an executive consultant in population health management with Medical Link, and some of my key areas of expertise include quality improvement programs and methods, practice transformation, healthcare payer experience, and program management. I hold a double master's in healthcare and business administration and currently pursuing a PhD in community health. Next, we have our co-host, Ashley Johnson, and Ashley will be assisting with the questions that come through on the question and chat box, in addition to assisting with co-hosting. Ashley is a community health worker supervisor with a background in behavioral health, and she has over 12 years of healthcare experience with an emphasis on mental health and substance abuse. She currently supervises a team of 12 community health workers aimed at identifying barriers to care and eliminating social determinants due to lack of community resources and support. Ashley is currently pursuing a master's in social work and has a passion for improving healthcare disparities. Our first presenter is Dr. Howard Haft. He has 27 years of clinical experience in primary internal medicine and 10 years of hospital-based emergency medicine, clinical, and leadership experience. He was founder, president, and medical director of Maryland Healthcare Associates, where he established a multi-specialty medical practice. And additionally, he was founder and president of Maryland Foundation for Quality Healthcare, which provided healthcare education to uninsured and underinsured Marylanders. Dr. Haft served as Chief Medical Officer at Health Partners, a Waldorf-based charitable clinic serving Charles County and surrounding areas. In 2015, Dr. Haft was appointed as the Deputy Secretary of Public Health at the Maryland Department of Health, and currently Dr. Haft serves as the Executive Director of the Maryland Primary Care Program, providing leadership and overseeing the day-to-day operations of the program. Our next presenter is Dr. Nkem Okeke. Dr. Okeke is a Kaizen-spirited healthcare executive with combined 20-year clinical and administrative experience in primary care and patient-centered care redesign. In the last 10 years, she has led and supported several primary care transformation and population health initiatives with focus on provider engagement, quality improvement, and payment reform. She served as the National Learning System faculty lead for Comprehensive Primary Program, also known as CPC Plus, at Booz Allen, and she served as special project directors for population health initiatives for Priority Partners. Before that, she served as the regional telemedicine coordinator at Kaiser Permanente prior to joining Hopkins. She is the founder and chief executive officer of Medical Links, a healthcare advisory and population health management firm here in Maryland. Her passion is to better integrate healthcare delivery systems. So those are our presenters for today's training. I will introduce our guest speakers towards the end when it is their time to speak. For the presenters, one last thing that I do want to call out is that all the presenters, they do not have any disclosures directly related to this presentation. So that concludes the opening remarks from me. So without further ado, I'm going to turn it over to Dr. Howard Haft to start the training. Take it away, Dr. Haft.
Thank you very much, Angelica. This is Dr. Howard Haft. I'm very pleased to be with my friends and colleagues this afternoon as we talk about how Maryland safely reopens our businesses, our healthcare offices, our economy, and even in the midst of COVID-19. And go on to the next slide, please. So this has been a really challenging time for all of us. We've seen in the last 90 days, more or less, things that we haven't seen accumulated in the last century. A pandemic, the likes of which we last saw in 1918 was the flu pandemic. A serious setback in our economy that we haven't seen the likes of since the Great Depression in the 1930s, and civil rights movements and activities and protests that we haven't seen since the 1960s. And we've seen all of those things in the same or larger magnitudes, all within 90 days. So I think this quote that these are the time that try men's souls is quite appropriate. The summer soldier and the sunshine patriot in this crisis shrink from the service of their country. But he that stands by it now deserves the love and thanks of man and woman. Tyranny in our context, it's COVID, the economy, civil rights, like hell, is not easily conquered. Yet we have this consolation with us, that the harder the conflict, the more glorious the triumph. What we obtain too cheap, we esteem too lightly. It is dearness only that gives everything its value. Heaven knows how to put a proper price upon its goods. And it would be strange indeed if so celestial an article as freedom should not be highly rated. That was Thomas Paine in 1776. And we think about that, the Revolutionary War as just being a war against England and freedom. But really, it was far more than that. It was about the economic survival of a new country, and it was about civil liberties that were being established. And all of those things that we see now, the health, the economy, all those things were still at play at that time. So in so many ways, we're now at one of those times by men's souls in which our real mettle will be tested. And particularly, this is the time in a moment in time where healthcare, and primary healthcare particularly, will show its real value. Let's go on to the next slide. So this is a timeline, and we'll just keep going through the different timelines. I'm not going to stop and talk about each of these, but I want to point out that in these 3 months, since the beginning of March 3rd through where we are now in June 18th, there have been 46 executive orders by Governor Hogan, significant orders changing the way that we lead our lives, the way we deliver our health care, the way we test people, the way we regulate, the way we inform, the way we do virtually everything, both in a restrictive way, and then even within this 9 months, in a way that becomes less restrictive. I'm sorry, within 3 months, way that has become less restrictive, kind of a wave of things being imposed and things being released. 46 executive orders, 37 secretarial orders during this period of time, and then also 25 individual orders that related to individual counties and the cities. So this has been a time of unprecedented time of changes in the way that we govern, in the way that we order our society in very, very rapid sequence. And you have been at the center of that, of those sequences, and seeing ways in which it has affected you from going to a place almost immediately where you were not providing any face-to-face care, to doing things with testing and understanding PPE and a whole host of other things within your practices, to now being encouraged, strongly encouraged, to get back to delivering a hybrid version of care, which is probably better than will ever was in the past. In many ways will evolve into something that's better yet for the future. Next slide. So where are we now in terms of the overall picture for Maryland? So if we look at these two charts on the top of the page, cases and deaths by age, we've had more than 2,800 deaths in the state, but it's been really very disproportionate in terms of the total numbers and the impact. It's been largely in the older individuals and individuals with underlying conditions. In terms of the overall death rates. In terms of the impact, in terms of positive cases, not so much. The impact spread, anyone can get this condition, no matter how young, no matter how old. But the adverse effects, either hospitalization and or death, is clearly in the older group, over 60, much more over 70, and very significantly over 80, as the graph shows you. And that's something that has persisted not only here in Maryland, but across the country and globally. We also really now, with the picture next to the right, you can see how in the lines, the blue lines going up, how we've increased testing over time. And the governor's been very clear about we need to be testing 10,000 or more per day. And we've been doing that here in the last several weeks. And we're testing significant numbers of individuals in many, many ways, it made much easier than, as you recall, the beginning of this pandemic. But even as we test, we've seen that the number of positive cases has been relatively, the percent of positive cases has been dropping down. We're seeing more cases. Every day we see cases, hundreds and hundreds of cases every day. But the percent relative to the population overall is continuing to decline because we're testing asymptomatic individuals. And in many ways, we've seen the peak. In every way, we've seen the peak of this pandemic for Maryland for right now, for this phase of this curve, in and around mid-April. And since then, it's been a steady decline in hospitalizations, a steady decline in death rates, a steady decline in the percent of patients when tested that are positive, all those being very, very good indicators, to the point now that although we've had more than 62,000 confirmed cases, we've tested almost 400,000 individuals. About 7% of the state overall has been tested. I'm sorry, the 526,000 total testing, 378,000 negative, 5.81% of positives, and 2,866 deaths so far. Sadly, most of those deaths occurring, the majority of those deaths in individuals in congregate living facilities like skilled nursing facilities. There's still in around 600 to 700 people every day who are in the hospital, but that's in all 45 of our acute care hospitals. So it's not any large number in any one hospital. Next slide. So all of that is to say that in many ways we're past at least the initial part of the epidemiologic curve. We went up, we peaked and plateaued, and now we've been steadily coming down. What we don't know is what's going to happen next. The virus has not gone away. And history tells us, if we look back at other pandemics, and the flu pandemic of 1918 or others, that as long as we haven't done anything to eliminate that contagion or to treat it, or a vaccine, that we still are at risk for coming back again. And many models say it will come back late summer or late fall, but the true answer is that it will come back only if, and to any great extent, only if we're not doing the simple things that we need to do. On one hand, making sure that we're attending to those individuals who are at high risk and keeping them out of harm's way. Those are those that you care for, the patients who are older, the patients who have multiple medical conditions, and doing it in a safe way. And that's what this presentation is all about how to do that and do it in a safe way. But if we do that, and if the general public adheres to simple things like wearing facial coverings and doing social distancing and hand washing, and if businesses adhere to the best practices, we can get through this with very little additional in the way of peaks until we get a vaccine. But if not, there are stop signs. Any unexpected increase in hospitalizations or sustained increase in cases that require intensive care and sustained increases in cases over a period of 5 or more days is a stop sign that says, let's stop releasing the pressure. Even though we do need to get people back to work, and we need to do it in a safe way. If there's an increase in number of daily COVID deaths, that's a stop sign. We're doing something wrong or too much. Let's either stop what we're doing or let's walk it back if we need to. Indications that Marylanders are disregarding physical distancing guidelines is an indication that we've taken a lackadaisical attitude about this, and that will come back to hurt us. Significant outbreaks of community transmission, if they occur, not a cluster in a nursing home or a single cluster in a business or something, but if we start seeing this overall testing strategy that we see, which has had a steady decline in the percent positive cases, if we start seeing that rise up significantly, that's also a sign that that something wrong is happening for one of those reasons, and we may need to go back. But it's really up to all of us to ensure that we don't have to do that. It's what we do to be safe in the offices, but what every other business does across the state and what the public does. But together we can do this. So I think that's really my message for you. And this is all designed, this entire program is designed to provide useful tips and help for your workflows, for you to enhance things that perhaps you're already doing, or give you new ideas on how to do those things better to keep yourself, your staff, and your patients safe as we continue through these next 6 to 8 months of COVID-19. I believe the next slide, I'll turn us over to my good friend and colleague, Dr. Nkem Okeke.
Thank you, Dr. Haft. Hello, everyone, and good afternoon. Dr. Haft has summarized our journey, the timeline up until this point. And in this session and the following session of this presentation, I'll be expanding on how we should safely reopen primary care delivery during the COVID pandemic. So the focus here is safety. Safety for ourselves, safety for our practice staff, and safety for our patients. Although the COVID pandemic is a public health crisis and has been addressed as such so far, the integration of public health efforts with primary care has never been more crucial, with the imperative to preserve ICU beds, inpatient essential healthcare workers for emergent and critical care. Our patients need to have more access to their primary care providers and specialty providers to address their healthcare needs. Practices are to work towards resuming or maintaining essential healthcare services using a risk-benefit analysis for inpatient care visits while we're still optimizing the use of telemedicine. The goal here is to discuss how we should maintain and increase our patients' access to primary care, both in an innovative but safe way. So I'd like us to start off with a poll just to determine what stage you think you're in reopening your practice, mainly based on your practice's capacity pre-COVID. So please select one of the following options. Are you in the pilot stage, just getting started, stage 1, stage 2, or 3?
And for those that may have joined in late, to participate with the polls, all you would have to do is just click on the radio button next to the answer that you would like to select. And we'll give it about 5 more seconds. So if you haven't voted yet, please lock in your answers now. All right, we're gonna close the poll now.
Thank you for your responses. So looking at the result, the poll shows that you have about 25% of us who are still in the pilot phase or stage, 32% in stage 1, so less than 50% reopened. About 20% of us are in stage 2, about 50 to 70% reopened, and 19 are greater than that. So hopefully as we go through the next series of information in the slides, we can, speak more to things that you can do to advance as you go with reopening in a safe way. And we also will hear from our guest speakers about how they have been able to reopen their practices safely. Okay, the key objective of this presentation is that you walk away with a good understanding of the reopening activities and requirements involved in establishing your recovery prerequisites, the pilot stage and the phasing stages of reopening, and research preparedness. Most of us have already established recovery prerequisites by now, and let's review prerequisites along the key categories. Infrastructure, which will include technology, physical space, and so on. People, your practice staff planning, and then new and modified processes and policies. To redesign the flow of your office, as you call it, feng shui, you have to consider your physical space. So consider keeping the chairs at safe distances, 6 feet apart. Remove potential vectors for infections, such as magazines. Make sure you provide supplies, such as tissue, hand sanitizer, trash can for disposal, and also ensure that your office layout is in some distance between the patients who come in for COVID testing from other patients or with symptoms and from other patients who are asymptomatic. For your staff, you should ensure that your layout promotes physical distancing. To learn more about ways that you can modify your space for safe distancing, click on the CDC link you have here. And remember that all practices have different sizes, have different needs, different capacities. So tailor these recommendations to your specific office layout. For those of you in the MDPCP program, you can reach out to your practice coaches, your CTO to brainstorm what might work best for you and stay nimble to adjust as needed. It is advised that if you can, secure at least 1 week's worth of PPE supplies at all times. First, determine your practice burn rate for masks, gloves, face shields, and other supplies. And then you can establish a purchase schedule to reorder supplies. Use these links below to identify suppliers and vendors that you can use and negotiate with at least 2 or 3 of them to get a reasonable pricing and delivery schedule that'll work for you. Also require proper labeling lab forms to submit your test samples and enough kits for testing. Almost all practices now provide telemedicine. So continue to enhance your practice's capacity to provide telemedicine. You may need to identify an alternative telemedicine platform as your backup telemedicine solution. I'm sure some of you have already experienced when you're about to start the consult with your patient and then the technology wouldn't work. So it's good to have a backup plan just in case you need it. Also consider affordable and free telehealth platforms that your staff can use to conduct care coordination virtually as needed instead of just using a telephone call all the time. You can click on this link to see a long list of telemedicine and virtual service providers that you can use, and there are more than enough telemedicine and telehealth solutions right now at your disposal. The next prerequisite we're going to talk about is your practice staffing. What adjustments do we all need to make to our staffing schedule based on safe distancing, based on office or in-person patient volume? Can some practice staff work from home? And do they have a laptop and required EMR access to do so? For staff who do come into the office, consider a COVID screening procedure, such as logging in daily temperature checks and assessing symptoms. The last set of prerequisites include your practice processes and policies. You need to modify your office safety procedures and policies on the following: environmental safety, staff safety, and patient safety. And then you have to educate your staff and your patients on the changes you've made to your safety procedures and policies. For environmental safety, some modifications you need to make to your existing safety protocols may include sanitizing and disposal procedures. You can click on this link here to get more tips on ways that you can improve the safety procedures in your practice. For staff safety, we've already discussed staff COVID screening and symptom assessment, so document a standard policy for this and communicate that with your staff. You should also define the proper use of PPE, safe practices, proper hand washing, and the new staff scheduling protocol. More importantly, you should also establish your staff self-care policies and access to self-care resources. In addition to establishing the COVID screening for your practice staff, in the unfortunate circumstance when a staff member is diagnosed with COVID, you need to have already established a protocol or policy for when and how your staff can safely return to work following recovery. The policy should also cover COVID-exposed staff members that may be contact traced within a period of time and consider how they could telework during that period. The CDC in the interim gave some recommendations on the criteria to return to work for healthcare professionals who are suspected or confirmed to have COVID-19. For those who are symptomatic, you can use one of two strategies. You can have a symptom-based strategy or a test-based strategy. If you're using the symptom-based strategy, exclude the personnel from work until they meet one of the two criteria. First of all, they have to have at least 3 days that have passed since recovery, which is defined as resolution of fever without the use of fever-reducing medication, and improvement in respiratory symptoms such as cough, shortness of breath. And secondly, they have to have at least 10 days that have passed since the symptoms appeared. If you use the test-based strategy, exclude the personnel from work until they have met the 3 criteria, which includes resolution of the fever without the use of fever-reducing medications, and improvement in respiratory symptoms, e.g. cough and shortness of breath, and negative results of an authorized COVID-19 molecular assay with a total of 2 negative results. For asymptomatic personnel, you can use one of the 2 strategies, time-based strategy or test-based strategy. For time-based strategy, exclude personnel from work until 10 days have passed since the date of the first positive COVID-19 test, assuming that they have not subsequently developed symptoms since their positive test. For test-based strategy, exclude from work your personnel until they've had negative results of an authorized COVID-19 molecular assay with a total of 2 negative results. You can visit the CDC website using this link to learn more, but please plan for this before you need it. Now on to patient safety. Update your patient safety protocol. Consider limiting patients' companions during in-office visits and patients' appropriate use of PPE. If possible, set aside a waiting area for patients who come in for testing. If you have designated COVID and non-COVID areas, that's a great idea, but you have to observe and minimize patients and staff crossing between both areas. After establishing these safety protocols, you need to communicate with and educate your patients on the office protocols and safe practices. Keep patient education and communication simple. Here are links that you can use to download information on some safe practices that you can share with your patients, especially about using masks. And always remember, my mask protects you and your mask protects me. Now that we have established all these updates to your environmental, patient, and staff safety protocols, you need to be proactive and creative about the frequency and channels of communication, both to your staff and your patients. What information should be communicated on a daily basis, on a weekly basis, on a monthly basis? Consider topics that you communicate, such as updates to safe practices, self-care, PPE use, and so on. What communication channels will you use? Email, your patient portal, notice board in the waiting area, staff meetings, website updates, your practice Facebook page. Keep your patient and staff engaged and as calm as possible during this period. Timely, frequent, and accurate communication is very, very important. So have a communication plan in place and update that plan as often as possible. To wrap up this session of the presentation, before we take a quick break, let us take another quick poll to gauge how we can observe the 4th quadruple aim on provider and care team well-being. Have you established an employee self-care policy for your practice? Please select one of the following options.
So if you haven't done so already and would like to participate in the poll, please lock your answers now, and we'll close the poll in about 10 seconds.
Okay, so reassuring result there, seeing that 39% of us already have it in place, a self-care policy for ourselves and our practice staff, and 37% of us is a work in progress, and 24% haven't yet started. So for those who haven't started, I hope you're encouraged. We have additional resources in the links we'll show you in coming slides that you can use to at least establish what those are. There are links, either telephone lines that your providers and your practice staff can call. You also have team building efforts and information that you can share within the team about how to deal with stress on the job, outside the job. So please do take the time to do so. So with that, I would like to thank you guys for your time, and we'll be back for the next session after we take a quick break. Back to you, Angelica.
Thanks, Dr. OKK. So, like I said, in the beginning, we do have 2 10-minute breaks scheduled for the training. It is now 1:40, so we'll take the first 10-minute break now, and we'll reconvene at about 1:50 with the rest of the training. Thank you. So welcome back from break. So we're going to reconvene with the training now.
All right, so now we have had an in-depth discussion about the prerequisites for reopening primary care, and the next steps we will be discussing will be piloting and phased-in reopening. As I always encourage my colleagues, first test your theory. Develop your updated workflows for inpatient visits and virtual visits. And the important things to clarify your workflow include how you address patient stratification. Continue to reach out to all your patients, especially those who are high risk, for ordering physicians that are CRISP participants with executed lab request reform within the system. Chris will provide you alerts when a patient tests positive or negative, so you are informed. For those of you who are in the MDPCP program, you also have the CRISP Pre-AH tool that now includes the COVID index that helps you identify your COVID at-risk patients that you can outreach. The second thing to think about is how you tele-triage. Triage your patients to determine if the patient should be scheduled for an in-person or telemedicine visit. After you've done so, you should also have a standard telemedicine visit protocol to learn more about telemedicine implementation and telehealth codes and see how you can tweak what you already have that exists. To learn more, you can click the link you see here at the bottom of your screen to get more guides or guidelines for telemedicine. One thing I wanted to point out to you here is that the HHS Office of Civil Rights issued a notification of enforcement discretion to empower covered healthcare providers to use communication platforms more widely than prior to COVID-19. However, under this notice, the healthcare providers may use popular non-public facing applications that are HIPAA compliant. So when you use that link, you'll be able to see a list of vendors and telehealth and telemedicine platforms that have HIPAA compliance. So be wise as you choose this, because we want to make sure that we deliver telemedicine, care through telemedicine appropriately. All right, so with your telemedicine visits, ensure that you maintain a smooth handoff between the MA and the person who's virtually rooming the patient. Make sure that you have good website manners. Appear professional. If you'll be typing during your progress notes during the visit, let your patient know so that they see you looking away means that you're actually trying to type in something and not that you're ignoring them. Also explore how you can better conduct physical examinations, utilizing both your visual observation, common vital signs. See how you can engage the patient to help you actually do physical examinations. I normally use a technique which is see one, do one, teach one, and that kind of helps to make the consult flow more smoothly. I would like us to look at a short video on how to conduct a physical exam using telemedicine, just to put things in perspective for you.
Hi, I'm Dr. Tanya Elliott, and I'm going to walk you through how to do a physical examination through telemedicine. So it was William Osler that said that medicine is all about the art of observation. So the first thing I do after I connect with the patient and consent them to do the video consultation is evaluate their general appearance. Are they ill appearing? Do they have pallor? Are they diaphoretic? Are they flushed? Then if I feel like I need vital signs, I ask them if they have a thermometer at home, and just to go ahead and take their temperature to show me what the reading is, and then I can document what the result is. Some patients also have a home blood pressure cuff, so that's another thing I'll ask them to go ahead and get to take their blood pressure and pulse if it's relevant. If patients don't have one and there's somebody that you see chronically and you'd like to have that as a regular vital sign, you can just ask them to go ahead and pick up a straightforward blood pressure cuff and then show you the result on the reading, and you can document that. Respiratory rate is something that you can calculate as the patient is speaking with you. Next, let's do the head, ears, eyes, nose, and throat examination. So is the head normocephalic and atraumatic? Next, look at the eyes. Are the pupils equal and reactive to light? You can ask them to look up, down, to their left, to their right, diagonally. And with that, you're also documenting aspects of a neurologic exam. You can actually do a cranial nerve exam as well, with the exception of the olfactory nerve, which is often also deferred in the office as well. If you want to look in the back of the throat, have them open their mouth, stick out their tongue, and do a big ah into the camera. If for some reason you can't see, you can ask them if they're on their smartphone to just adjust their angle. I also sometimes will ask patients to grab a flashlight or use a flashlight on their smartphone to be able to see down into the back of their throat. We can also evaluate the sinuses. I tell my patients, okay, now you are going to be my hands for me. Take 2 fingers, tap here, and let me know if there's any pain. Use a moderate amount of pressure. Same thing here and here. Let me know if there's any pain or any difference on either side. And then I can document whether or not there's any maxillary or frontal sinus tenderness. Now again, the only difference then when they're in the office with you is the patient is being your hands for you, but the response is still subjective, and you can document that on your physical examination. The next thing I ask patients to do if I'm concerned and I need to evaluate for lymphadenopathy is I teach them where the sternocleidomastoid is on either side of the neck. Take 2 fingers or 1 finger, depending on how big their hand is, and feel for something that's pea-sized or greater down the anterior and posterior chain. Now, sometimes patients get this, sometimes they don't. However, if it is a large lymph node, they should be able to feel it, and then they can actually show you exactly where it is and whether or not they can grab onto it, whether it appears to be mobile or fixed. I also will ask them to feel here and here to evaluate whether or not there's any submandibular tenderness. The next piece is the respiratory exam. Now, a lot of times doctors will say to me, well, you can't do the respiratory exam because you don't have a stethoscope. Well, there are aspects of the respiratory exam that you can do through a video visit without a stethoscope. So first thing I do is ask my patients, take a big deep breath. Now, I see whether or not they're coughing in the middle of that. I see whether or not there's an expiratory wheeze, whether or not that's relevant for you and in the context of the patient. I also evaluate whether or not the patient is using any accessory respiratory muscles for breathing. Nasal flaring, use of any neck muscles, any paradoxical breathing where the abdomen is moving differently from the way that the chest is moving. And then all of that can be documented. The next part of this video series, I'll walk you through how to do an abdominal exam, extremity exam, and musculoskeletal exam all through video. The last piece I'll say is with regard to a skin exam, when you're thinking about using a telemedicine platform, make sure that you're able to upload a photo during the visit. That's what I found to be most effective. So if a patient has a rash that they'd like to show you, they can switch over to the camera mode, take a photo, and upload the photo. If you're using a non-HIPAA compliant software now during this time of COVID-19, that's fine. They can take a photo on their camera and then send it to you via text message. And then you can zoom in to see whether or not there's any pathology there. If you're concerned about hives or whether the rash is blanching, you can have them do that in real time via video. Ask them to press down on the lesion, hold up the area close to the camera, and then see whether or not it's blanching. That's all for now. Thanks for watching.
Okay, so I hope you found that somewhat helpful, the tips how to check for vitals, do a respiratory exam, at least to an extent, using telemedicine visit. You also have other links in there as, that she also did to show you how you could do an abdominal examination through video or musculoskeletal examination. Also, there's a link in there, it's like a download of a flyer for your patients to show them the proper way to do a BP check at home. So moving on to office visits, consider using a triage zone for your inpatient triaging. Consider scheduling different days or times for at-risk and vulnerable patients, and schedule more time in between visits to limit the exposure between patients. You should determine in-office COVID testing protocols. For example, if you have symptomatic patients, should they wait outside? What should your protocol be, and educate your staff on that. Also establish how you can communicate results to COVID positive patients, how you should be sensitive about it, how you should advise them on your referral pathway or next steps. And for those who would be needing extensive treatment and care, how can you best support them? So looking at telemedicine and the different virtual visit codes that are available, but the HCPCS codes and CPT codes, CMS and other payers have made it sort of easier for providers to provide telehealth care. So we have a couple of waivers based on patient location. So now patients can be offered telemedicine services at home. You have waivers for practicing across state lines, but you still are subjected to requirements as set by the state. Providers can also see both new and established patients using telemedicine. The list of services have expanded quite significantly since the COVID pandemic. Here's a summary of the HCPCS and CPT codes you can use, and this cuts across telehealth consultations, virtual check-ins, and e-visits. You can also click on this link you see below for a complete list of Medicare telehealth codes and to learn more about telemedicine billing and coding. Currently, there are ongoing conversations about regs to extend reimbursement for telemedicine post-COVID. So we'll see how this pans out. So now that we have looked at all the different elements and you started off with trying things out and piloting, to summarize, we've reviewed the updates of the protocols that you can have or make for your practices, the telemedicine billing codes that you can use, and now you can start the pilot, observe the process, and see how things go and make changes as you go along. The key things to keep in mind are that before the patient arrives, prepare the clinic, waiting rooms, patient rooms, being mindful of trying to limit exposure. Also think about when the patient arrives, ask the patients more about their symptoms, and remember to separate sick patients with symptoms. After patients are assessed, you flag the patient with COVID-19 symptoms in your EMR for the most part for investigation. And of course, remember to clean up in between patients. You can use these links here for more resources on patient rooming, scheduling, and so on and so forth. In stage 2 of the reopening, which most of us are already in. If I recall what the poll said, we're about 38 or so % of us in that phase. You should have already started building upon the process that you've established in the pilot stage, and then continue to adjust your staff capacity, bringing in employees back in phases, and maintaining a modified schedule. Consider maintaining telework where possible. Also, you can gradually increase your in-person office visit volume, and you have to kind of match that with your staffing capacity. And you can also expand on other things, including your follow-up, testing efforts, and referral pathways. At this stage, you want to consider having your practice staff use telehealth as well, because right now a lot of things are telephonic, but just in case there are other free and affordable telehealth platforms, you should also encourage virtual visits for care coordination. You should pay attention to the community health support that your patients might need. Consider that some of your patients have all the social needs that they need to address, even with the pandemic. So during this time, you can identify ways that you can have your practice staff, care coordinators, care managers support the patients to connect them with resources. Here is a list of resources that you could use to help your patients address their social needs. So now we'll take another poll. Besides PCP telemedicine encounters, do your practice staff use video visits for care coordination?
Thanks everyone that has voted so far. If you do want to participate with this poll, now is your time to lock in your answer by clicking the radio button to the answer to the question. And we'll give it about 10 more seconds before we close the poll.
Yeah, so this is very reassuring to see at least 34% of you have your practice staff use video visits. And let's remember that right now, as we work with our patients, there's also, a psychological component to this. So being able to see when it's convenient for them to see their members of their care team is also helpful besides their primary care provider. So 9% of you rarely do it at all, and 56% of you do not do it at all. So as you begin to think through what reopening would look like and have a more rounded and comprehensive approach to care delivery, these are things you can consider. And the reason why I'm speaking to this a little bit more is we know that at least for some practices, they have been charged extra to be able to have expanded telemedicine platform on their EMR. So it's good that you know that there are free and affordable platforms out there, so you're not limited to what you could do with virtual visits for your patients. All right, so in stage 3 of reopening, and here we refer to stage 3 pretty much as when practices are closer to their pre-COVID capacity. So you should build upon the progress that you've made so far from pilot to stage 1 through stage 1 and 2, and adjust as you go along. Things you have to always keep in mind is adjusting your staff capacity, understanding what you could do using teleworking versus not, and the in-person office visit volume, and what makes the most sense, and how can you reschedule and stagger things around so that it works for you. Next slide, okay. And we are going to take yet another poll, again, just to gauge where you are with using telemedicine, because a lot has been done. We've become more creative about ways that we can apply telemedicine. So before we're asked or we're told what is going to be billable, reimbursable, and all that good stuff, I just wanted to get a read of the room. What do you think is the best option that applies to you currently and in the future? Do you think you're currently now you're doing 70% telemedicine, and in the future you would do more than 50%? Or right now that you're currently doing at least more than 70% telemedicine, in the future you see that being somewhat less than 50 or even lower than that, less than 20?
Thanks everyone that has locked in your answer for this polling question. If you haven't done so already and want to participate in this poll, please take some time to click the radio button in which best fits you in your current state where your practice is. We'll give it about 10 more seconds before we close the poll.
Okay. Wow. So we can see the results here, and 24% of us currently use more than 70%, and in the future, you see yourself using greater than 50% of telemedicine for care delivery. 54% see as less than 50, and 23% less than 20. So one thing I wanted to call your attention to is that we all have to work together to make our case for what is going to be the future of primary care post-COVID. So based on hands-on, there are a lot of things we're doing now that nobody knew we'd be doing. There are a lot of unanswered questions, even though we have some answered questions. So as we begin to formulate, quote unquote, what primary care would look like post-COVID, most of us, on this webinar will be part of the leaders that we pull together to discuss what are the recommendations we can make, both at the local level, state level, federal level, to really redefine what's the best way to move forward, be in a safe way, and continue doing the great work we do to support our patients, and definitely see the kind of health outcomes we're looking for. It will be very interesting at the end of this, so as time goes on, to kind of look at the different care delivery models and types that we've been doing, both in-person, telemedicine, and kind of map that against health outcomes for our patients, and see if we can begin to have, statistical supported outcomes of how this new normal is going to improve healthcare outcomes for the most part, especially if we have to have a research. Thank you. Next slide. So while we do not wish for another wave of rising COVID-19 incidents, we don't know. So we should stay prepared for a resurge in some ways similar to what we do with the flu season. So we should stock up as much as we can as we identify the best pricing that's out there across all suppliers. Let's at least keep about 3 to 4 months of inventory to plan for the rainy day. Consider pre-planning for staff telework setup. This would mean securing laptops, connectivity, different, calling solutions, cell phones. There are other phone and telephone platforms that are secure and HIPAA compliant. And also consider being flexible depending on what your patients might request or need. Some patients may be more comfortable with actually doing telemedicine visits. Some may be scared enough that they want to show up. So also put that in perspective. We should continue to stay up to date with Maryland's recovery status on the incident rates of COVID and what is being done from a state level and down to the local level, the county level, and then rely on trusted sources for information like Maryland Department of Health, the MDPCP PMO, and the CDC. In case of a resurge, you have to plan for stricter enforcement of your practice safety procedures and guidelines, which you are currently modifying. Wind down on in-person visits as you see fit, and make sure you have a staff work schedule to accommodate for that. You will definitely need to accelerate telemedicine, telehealth visits, and things like that, as well as testing. Practices are used to understanding what it is that they have to do to at least stay solvent in managing their practices, especially for those who are solo practitioners. But also, you're supposed to use a risk-benefit analysis to determine how you can safely open primary care to your practices. So speaking of risk-benefit analysis, things you have to consider include lives that are going to be saved, healthcare costs, impact to the economy that impacts your patients, impacts you as a provider as well. And these are things that we have to all kind of keep in mind as we do a risk-benefit analysis. 3 things that I want you to keep in mind include, first of all, the ongoing medical office operational risk. Based on a study that was done assessing overall patient safety in a practice, a breakdown of top risk categories for selected specialties show that the 4 most prevalent risks in family practice and in telemedicine include the following: telephone communication, informed consent, consultation tracking, and test tracking. These would most likely be worsened with the COVID-19 pandemic. So revisit and improve whatever risk mitigation strategies you already had in place to assist you with preventing the risk associated with these following items. Some things you can consider include using a standardized format and workflow for managing and documenting calls during office hours, after hours, conducting meaningful informed consent discussions with your patients in terms that your patients understand, and paneling your patients and assigning care teams roles so people know who's accountable for what and who's supporting with what. Use your EMR functions to provide automations for steps to track your processes. You can also identify a mechanism such as secure patient portal letter telephone for communicating results and so on and so forth. Secondly, the risk of exposure to COVID-19 and the associated impact is something you should also keep in mind as you do your risk-benefit analysis. We already talked about having staff do symptom assessments, safe return to work with confirmed or suspected exposure, safe distancing, and how you can modify your staffing plan and patient office visit schedules. So hopefully these helpful tips, you can use them to actually identify how to best manage your risk assessment analysis to reopen your practice. The third one is the risk to patients. You can imagine that during this time, routine care for your patients has been impacted. But now we need to begin to understand ways that we can support our patients for care that they need that cannot be serviced by telemedicine or telehealth, immunizations, preventive care, and so on and so forth. So here are a list of resources that you can use, and this cuts across everything we've discussed, from recovery prerequisites and things you can use, and this is from different trusted websites, CDC, MGMA, AMA, and also the state, also about piloting, about telemedicine, and other things that you can use as a guide. And this wraps up this part of the presentation. So we would like to also hear from our guest speakers. We have about 3 of them who are here to share their experiences with reopening. And I'll be here at the end of the presentation along with the guest speakers as well for the Q&A session. So thank you for your time, and I would hand this back over to Angelica.